We're showing biomarker data at this AACR meeting 2018 for head and neck cancer patients treated with a PD-1 inhibitor, treated with pembrolizumab. These are data from the KEYNOTE-12 and the KEYNOTE-55 studies. So it's a relatively large cohort, about 250 patients treated with a PD-1 inhibitor. We're looking at 3 biomarkers, all of which I think have potentially clinical relevance. We're looking at especially tumor mutational burden, and then an inflammation signature, generally abbreviated as GEP or gene expression profile. I don't think we have any PD-L1 data that's already public, but I think it's the largest data set for head and neck cancer looking at tumor mutational burden and the inflammation signature. KEYNOTE-12 and KEYNOTE-55 are studies that show efficacy of pembrolizumab for head and neck cancer. In fact, KEYNOTE-12 led to approval of pembrolizumab for head and neck cancer in the United States. These are now the biomarker data, looking at the tissue samples, trying to see if there's maybe a way to better predict which patients benefit. The problem obviously is that only about 16 to 20% of patients benefit from pembrolizumab. And this data set looks at RNA, looking at inflammation genes, gamma interferon, etc., trying to predict which patients benefit on inflamed tumors, and then also looks at the number of mutations. Again, the suggestion is that maybe patients who have higher mutational burden are more likely to have benefit from immunotherapy. They might have more antigens, and both of these actually work quite well. Right now, I'm not sure that for head and neck cancer it's quite yet ready for prime time, but I think we're getting close. In fact, at this AACR meeting, we're starting to see data for tumor mutational burden in lung cancer that maybe we can predict which patients have more benefit. Our data is interesting in the sense that all 3 biomarkers work well and can actually enrich for patients with benefit. Neither of them are perfect in a sense that you cannot for sure say you have a lot of mutations, you'll benefit or not benefit, but they all enrich for benefit, and they're actually fairly good at enrichment. What is interesting is that they are not necessarily perfectly correlated. So inflammation, GEP, and PD-L1 have some level of correlation. They measure in the tumor presence of inflammation, presence of immune cells. By contrast, tumor mutation burden is not well correlated. It measures something very different. Both GEP and PD-L1 correlate with benefit in respect to progression-free survival and overall survival. Tumor mutation burden only seems to correlate with benefit from progression-free survival and not from overall survival, and I'm not sure that I fully understand why that's the case. So they're different in their flavor. What we don't quite yet know is how do we put them together? Is there a way to actually, make a composite biomarker? But they both, or all 3, are potentially ways to select patients for studies, and we're already seeing this. Some studies, like in lung cancer, enrich for PD-L1, enrich for tumor mutational burden, and I think that's what we'll see for head and neck cancer as well. And this is a data set that provides the basis for that. So I think we will see data forthcoming in the first-line setting for head and neck cancer. There is 3 large studies in the first-line setting right now. There is KEYNOTE-48, there's a Kestrel study, and there is Checkmate 651, so combinations of a PD-1 or PD-L1 agent with CTLA-4, or combinations of a PD-1 agent with chemotherapy, and also single agent first-line data. And so these studies will likely employ biomarkers such as PD-L1 or maybe tumor mutational burden. We'll have to see what actually comes out to select the right patients for those treatments. So I think within a year or maybe 2 years, we'll actually get those data, and these biomarkers will become clinically relevant, I would predict. I think these biomarkers are also important for the future in a sense that not only are PD-1, PD-L1 agents clinically meaningful, but we're also starting to think about combination strategies. And I believe these biomarkers will be key in identifying which combinations we should use for which patients. Maybe tumor mutational burden is particularly good for CTLA-4 combinations, at least the lung cancer data that we'll see here at AACR may suggest it. I haven't seen the details, but it certainly looks like this. And I would predict that there's a good chance that tumor mutational burden will find a role for CTLA-4 more commonly. I think there's a chance. What about other combinations? What about, we just heard that the ECHO 301 study was negative. That's an IDO combination study. We haven't looked at these biomarkers. Maybe GEP will be helpful there. IDO is certainly one of the genes in the GB signature. So I believe that these biomarkers will be helpful not just in enriching patients for the first-line setting, but I think they will also be helpful in identifying the right patient for which combination, and I think will lead to more personalizing immunotherapy. Which treatment do you get if you have which immunophenotype?